we should be live here in a second. I'm just waiting for the preview for Instagram. Okay, mine's live now. I got the messages up. Dr. Salem, is everything good on your side?
It is. It's great.
And lucky for everyone, we got Ari back this time, so that's awesome.
Hi, everybody.
We'll just give a minute for people to come on board. Already got someone there. So let me just kind of explain to everyone something that's new that we talked about last time that we're going to be doing. So our clinic is going to be offering lots of things, such as like some things like free cycles, free egg freezing. We're going to be offering discounts. We're going to be giving out over this next year with this show. And every several months, we'll start doing these raffles. And the way that people will be able to get into the raffle is you have to put in the question. So every show, if you have a question, you will get one entry into this raffle where we're going to be giving out these things. Okay. If you come on the show, again, you don't have to show your face, but you can just be there with audio. You get 5 entries into it. And you can only get an entry per show. So you can come on live and put a question, and that gives you 6 entries. You can just put 2 questions, you only get 1 entry. Or if you come on live twice the same show, which probably wouldn't happen, you would still only get 5. And so we want to really encourage people to be involved. And we thought what we'll do is to help you guys get involved is we're going to make it where you can actually win things. And so that's what we're going to be doing now. So I'm going to stop there for a second. Dr. Salem, you have anything to add to that, or just wanted people to know?
No, I think it's a super exciting program that we're launching here. And, it's an opportunity primarily to be front and center, ask your questions, put it out there, and then have a little fun and maybe get a little lucky in the background, because we are, we're very motivated to get people to come onto the show, and we'd love to have your participation.
And so even though we're going to be talking about egg freezing tonight, we want people to call in and we want people to send messages about egg freezing. Tell us about your case if you want us to tell you about it. You can still ask other questions, but our focus at first is at least going to be on this. And so, I think what we should do is let's start it off first with, I know we have someone already there waiting for us. And we'll kind of get Mallory on here. So, all right, I'm going to bring up Mallory. I'm going to remove you for a second. Hey, Mallory, can you hear us?
I do. Thanks for having me on.
Well, thank you for coming on. And just so you know, as we're starting this now, we are, anyone who comes on this show now gets entered into our raffle, which is going to be some pretty big things. So even full IVF cycles and stuff like that. And just by coming on, you get 5 entries into it. And questions get us 1. So you're the first, and so you probably should get extra for being the first, but unfortunately we didn't think about that before the show. But tell me about your question and what you have for us.
Well, first off, I want to say thank you to New Direction. I actually did already 1 IVF cycle with Dr. Derman last year, and I actually have 1-year-old twins from you guys.
That's great.
So I want to thank you guys so much again for your team and, being a great support for me and giving me my beautiful twins. But the question I have, of course, is now my second. I want another baby, of course, in the future. But I always hear these rumors about, after the first round of IVF, try doing it natural. Maybe your chances doing it natural again, you might have a higher chance. But the reason I did IVF is because I had infertility. So what's your guys' thoughts about us who wanting to do it again? Do we kind of waste our time again trying it naturally, or just because I already have great embryos with great grades already at your clinic, do I just jump in and do that again? What's kind of your thoughts on that?
Yeah. Dr. Sam, you want to answer that first?
Yeah, maybe I'll take this on first. It's such a great question, Mallory. And it's such a great question because it really does tie in my opinion, to, fertility preservation if you already have embryos frozen at our clinic. So it does tie in some ways to what we're talking about already tonight. Now, what you're asking is a really, really great question. but there is a lot of nuance to the answer. And I'll start by saying it really depends on why you went through IVF in the first place. So let me give you an example. If you went through IVF because, let's say, the tubes were fully blocked, well, the tubes aren't going to unblock themselves after you get pregnant. And so you're still going to be left, unfortunately, with the same problem. But the good news is you have embryos saved up, and you can use those embryos to become pregnant again. In other words, the reason for your fertility may not have changed. It might not have improved. Now, there's a whole other set of things that could happen. For example, let's say you had gone through IVF treatment because it was falling in the realm of unexplained infertility. And so you had been trying for a year, nothing had been working, went through IVF and it worked and great. You know, you had your twins. Now you have maybe 2 or 3, let's just pretend 2 or 3 embryos left over that are frozen waiting for you. And you're wondering, should I just try again for a few months to get pregnant on my own? Or should I just go back and use these embryos? They work with such high efficiency. And so if you're a candidate to kind of try again, and the short answer here as well is make sure to check in with your doctor, Dr. Derman in this case, to go back up over the reason why you went through IVF in the first place. But if you're a candidate, you can try again for a few months to get pregnant. And some subset of people, and it depends a lot on age, can get pregnant with their second child, you know, naturally. Now, the vast majority do end up still needing to use frozen embryos or need to go through IVF again at that point. But there is a subset of people that do get pregnant without using those embryos, get pregnant the old-fashioned way, let's call it. So great question. And I'll pass it over to you, Dr. Amos, because I think you'll have some different takes on it as well.
You know, you said it best, which is, I think it comes down to why you did, right? If there's a reason that can't, you know, that's not going to change, it's probably not going to help. So my wife and I did IVF. We never got pregnant accidentally afterwards because our cases were so severe that really IVF was the only thing. But there are a lot of people who jump into IVF maybe too soon, or maybe for stress reasons and things like that. And they just say, I want to do it now. And so I do believe those people might get pregnant accidentally. But what I usually tell people, and this is kind of my opinion, not fact, if you probably needed IVF, you're probably going to need it again. And the reason you hear those stories about, oh, you know, when they just stopped trying, they got pregnant, those are the rare stories. That's the ones that give us the hope. And in reality, usually if you need IVF, you need it again. But it comes down to, like Dr. Salem said, what was the reason? And if it was a major reason, then it probably, you're going to need it again. But I have seen cases where, like, I have people who haven't got pregnant for like 10 years, did IVF, had a baby, and they got pregnant again. As a matter of fact, one of our old nurses who went through, I want to say it was 3 IVF cycles to finally get pregnant. And then ended up getting pregnant multiple times afterwards. And she had to go through IVF, multiple failed cycles to get there. So it does happen, but that story is the only story I have of that. And most time, people do need to go back through IVF again. So that's my thing. I'm a little more pessimistic because I just feel like I don't want people wasting time. And I think that would be my caveat is this. Nothing wrong trying for 3 to 6 months. But if you're 41, don't waste your time for 3 to 6 months if you need IVF the first time. If you're 27 and you did IVF, go for it. Try for a year if you want, because you're so young, you have time. And I think that's the thing, is you have to balance all those things. But I really appreciate that question, Mallory. Hopefully we answered that well.
Thank you guys so much. No, it's just something mentally I've been thinking about, but I think you guys really explained that really good for me. I appreciate it.
Thanks so much, Mallory. So it's funny, like I said, when you're giving your answer, I was in my head thinking, I'm like, I get this asked all the time, and I feel like I'm always like, it doesn't happen. Like when it does happen, it's usually someone who probably didn't even need IVF. And I just think of my wife and I'm like, yo, I wish that story happened to us all those years. So
Yeah.
It looks like we had someone else, but I don't know if they're there right now. I do see a clinic right here asked about a question. How does your clinic do pre-genetic testing in-house, or do they send it out to an outside lab for analysis? So I can answer that. And I think, Dr. Sam, you can help me answer this. there are really not many places that do it in-house. Years ago, when it first kind of got around PGS, there were maybe like 2 clinics in the entire country who were actually doing it in-house. And everyone else was, having to use a company. And it was difficult because you would try to do this, then you were doing fresh transfers. And so what happened was, a long time ago, actually CCRM was one of the main ones, was sending everything off to this other lab. And that lab was doing it fresh. Another one was doing it with frozen transfers. And what ended up happening was they found the frozen transfers were even having higher pregnancy rates. And so that kind of in-house lab that it was better disappeared. And even the guy who actually used to, his name was Richard Scott, he used to go around the country telling everyone how they had to have their own in-house lab to make sure it was better. Even he finally admitted and said, yeah, you don't need it anymore. And so from that point, really very few, I honestly only know of 1 or 2, I think, that actually do it in-house, and almost everyone sends it off. And it always important to remember, they're not sending the embryo, they're just sending the cells they biopsied off. And in some ways you want to do that because just like you might be able to make spaghetti at home, but Olive Garden does it a little bit better. And so this is all they do for a living. And so and if you have it in your in-house, you might just, be putting a little bit in it, but they're always on the cutting edge. And so most places send off. And what do you say about that, Dr. Sam?
Yeah, no, definitely. It's a very interesting question in the sense that I think the natural bias is to be like, oh, we want the genetic testing to happen in-house and make sure that, the genetics are happening in-house. And I think there's 2 things there. The first is I think people worry that the embryo is being sent in the mail and then coming back. The embryo always stays locally in the lab in which it was created. It's frozen there. And there's just a few cells that have been taken off of the outer layer of that embryo. And those cells are the ones that are sent to the genetic lab. Now, even in places where they have in-house genetics, it's physically in another building, right? So the embryo still gets frozen somewhere, and then they send it out still, to get the results somewhere else. But it's just under the same, let's call it umbrella company or whatever. But this is there's so many analogies in other parts of science in which, you want to subcontract out, let's call it, some of the really highly super technical work. And this is one of those things that genetic testing companies are just so phenomenally well equipped to keep up with the rapid pace of innovation that in-house places are almost never able to do. And so I'm a big proponent of these genetics companies. The other part of it, to be quite honest, as a fertility clinic that I think is particularly appealing is that, Dr. Amos and I can compare different genetics companies and see who's on the cutting edge, who's doing the best genetic analysis, and effectively, help guide our patients to those places. And if there's a place that's not doing such a great job, maybe we don't use them. So, a little bit of competition in that sense gets better outcomes, and it has pushed the field further. So I really think it's wonderful that we can choose from a few different genetics companies that are out there.
Yeah, and when it comes to competition, the more companies are out there, there's more competition. Whereas if you're doing in-house, you're buying already a pre-made thing that's being able to do in-house. Rarely are you competing with them, and so I agree with you. It's better. Let's talk to Kate. Kate, hopefully you're ready here. We're gonna bring you on. I see you are. Okay. You want to put her on? Sorry.
Hello.
Hey, Kate. How are you doing?
I'm fine. How are you?
Fantastic. Well, thank you for being on the show. And again, to remind everyone, if you're on live, doesn't even have to show your picture. You get 5 entries into our raffle that we're putting together. Questions get you 1 entry per show. And again, we're going to have some pretty big prizes I think people are going to be excited about over the next few weeks as we do this. But tell us about your question you have for us that hopefully we can answer.
Okay, so it's actually not for me. I'll ask you my question about myself later on. It's actually for a friend. So I have a friend that has gotten pregnant naturally. She's been trying to conceive for numerous years. Been with various doctors. I keep telling her to come over to New Direction. So she has an appointment in 2 weeks, but I can't wait to ask her question just to get ahead of the game. She has gotten pregnant naturally. She was actually diagnosed through blood work with lupus. I'm going to mispronounce the second one. Androgens. Hold on.
So there's
Yeah.
something called lupus, and there's a thing called lupus people can have like antiphospholipid syndrome.
Dysplasia?
Yes. Yep. So that sounds like lupus anticoagulant or something like that.
That one. Yep, that one. I knew it was in my notes. I didn't want to leave to go back and get it. So yes, she's been diagnosed with that, but she's also had reoccurring miscarriages. So really concerned on how to have a viable pregnancy since she has done progesterone after she's been actually confirmed pregnant, but still has early on miscarriages. So how can she go about fertility? Like, does she need to do IVF? Does she need to do IUIs and then maybe be on something else besides just progesterone or even maybe progesterone shots?
Mm-hmm.
You might ask her age.
31 or 30. She's my age, so 30, 31.
Yeah.
Yes.
You got to know your friend's age.
Yeah.
I know. So wait, don't ask me too many questions.
You want to start this, Dr. Salem?
Sure. Yeah, I can. I'm happy to start it off. So, what we're talking about here is a diagnosis of something called antiphospholipid antibody syndrome, and it's not just the one antibody that would lead to the diagnosis. It's a little more nuanced than that, but we won't get into the weeds of that right now. But let's just pretend for people out there that have unfortunately experienced recurrent pregnancy losses. So they've had, they've had 2 or more early miscarriages, and they've been diagnosed with this condition. What this condition is kind of believed to do is to cause little blood clots within the vascular bed of the placenta. So as the embryo is kind of nestling into the endometrium, into the uterus, and trying to get a really good blood supply, parts of that blood supply are being cut off prematurely. It's kind of like, it's just not getting enough blood, and unfortunately, among other things, that leads to a miscarriage. So the one of the treatments that can be very helpful if this is the condition is to use a blood thinner. Traditionally, we've used things like Lovenox for the blood thinner, and they would be on Lovenox, for some duration of time from the very, very, very early part of the pregnancy throughout. Now, I think one thing that's very important to remember is that you can have this diagnosis and something else. And that's
she has a PCOS also.
Right. So there are these other complexities, other variables, and that's where it becomes hard to know, is this truly the only thing going on, or are there other things going on? And maybe what I'll do is I'll pass it off to Dr. Amos, because I think, he'll kind of continue on here.
Yeah. As Dr. Salem was saying, antiphospholipid syndrome is a really interesting thing because it's a syndrome. So when you hear about like PCOS, polycystic ovarian syndrome, and antiphospholipid syndrome, it's not a diagnosis. So most things have a diagnosis. Your blood pressure is a certain level, you have hypertension. Your glucose levels are high, you have diabetes. But when you're talking about syndromes, it's more of a diagnosis that goes, if you have this, and you have this, and it's not any of these, then you must have these other symptoms that can come with it. And that's what antiphospholipid syndrome is. Matter of fact, there actually isn't a test that makes you positive. So even when your test comes back positive, like your friends did, we still don't even consider the positive until it's done 12 weeks later and then it's still there. And even then, if it's positive, you still don't have the condition until you have one of the clinical conditions, which either has to be recurrent miscarriages, which she's had, or things like a blood clot in the venous or the arterial side, or an unexplained loss later in the pregnancy. And so, as he was mentioning, there are so many things that can cause miscarriages. Even PCOS itself can have luteal phase defects. And you mentioned about progesterone, and that hasn't helped it. And so what I do, and I'll kind of give you a little bit of idea of what her appointment would be if it's with me or with someone else, is that it's going through that history. And I really go through each single miscarriage. And I find out not just what did they do, not just what happened, but when did it happen? Was it 5 weeks, 3 days? Was the next one 6 weeks? Because the problem as a patient is that we only see everything as outcomes, right? In the end, whether you have a miscarriage at 9 weeks, miscarriage at 6 weeks, or miscarriage at 4 weeks, it's a miscarriage, right? And
Right.
you feel like, okay, they're all connected. But the thing is, they all aren't connected because different
Okay.
miscarriages happen at different times. And what's really interesting is I know Dr. Salem was talking about how the blood clots, but we actually don't know if that's the actual reason why the miscarriages happen. There's even questions about how does even Lovenox fix it if it's not blood clots. So it's a very interesting syndrome that causes miscarriage. And so I hope she doesn't have it because it's so stressful. But the point is, I think what the question you were coming on for is like, hey, what's going to happen? And as a doctor, we're going to look at that history, figure out, is there some connection? So someone's had 3 miscarriages in 9 weeks where a heartbeat's there and stops. That is completely different than someone who's had 3 miscarriages where they had a chemical pregnancy that went up to 20 and came back down 3 times in a row. I see that and I'm thinking things like, okay, is there something wrong with implantation? Does this person maybe having ectopics every time, depending on the rise? I even watched the rise of the ECG.
Mm-hmm.
Here's the good news for everyone, and Dr. Sam can add on to this. In the end, if you do the workup, most of the time, even if you don't find anything, which he talked about on one show, 50% of the time you don't even find anything, there are treatments that we do empirically, and over about 80% of people still end up going to have success. And so I think it's great that she's coming to see someone now, because keep in mind, OB doctors, they don't do what we do. They do their best to help. But as I always tell people, I would be very pissed if they could do what I do, because I had to do 3 years more of training. And if I had to do that for no reason, I'd be upset. So it's a big step she's taking. I mean, basically, specialist now. What do you think, Dr. Salem, to that?
Yeah, no, I totally agree with that. I mean, it also takes a lot of courage to kind of make that leap and say, okay, hey, there's definitely something going on here. We need to figure out what it is. And the treatment solutions are very different. You know, it's not a one size fits all. Like, hey, you had recurrent pregnancy loss, so you have to go to IVF. Not at all. So, and it's a very stressful thing to go through this. Now, I think the take home message that is important to keep sight of is the fact that even with 3 miscarriages, you know, the vast majority of women, their next pregnancy will go all the way to them taking a baby home. So it is a very, positive outlook on the whole, but it's still one in which we shouldn't be, we should be mindful of, and we shouldn't be like ignoring the workup and the treatment.
And you
Awesome.
mentioned, Kate, about IVF.
Mm-hmm.
Where a lot of people go on to IVF is when you can't find a cause for recurrent miscarriages,
Okay.
and you can't find anything. One of the questions that comes up is, could the embryos be abnormal? So when you look at all the different testing we do, that's the one thing we can't test. Until we take the eggs out of you and make a baby and test them, we have no idea if that person may have more abnormal embryos than someone else would. And so, like, I've had someone who was 20 years old came to me, had a bunch of miscarriages. I told her not to do PGT testing. This was back in the early days. And it came back and like 90% of her embryos were abnormal. And that explained the miscarriages. So that's why some people will do it, because it does 2 things. One, it gets rid of one of the more common causes of miscarriages. But 2, by removing that, then you focus on all the other things because you remove the most common cause. But it's, as Dr. Salem said, IVF, IUIs, none of those prevent miscarriages by themselves. But with IVF, you can add on testing for the embryos to remove that type of miscarriage, and you can sometimes find things that are wrong. But technically, the treatments themselves don't prevent the miscarriage. It's the treatments we do for the recurrent pregnancy loss that eventually help.
Okay. No, that makes sense. I appreciate it. Thank you. And I don't want to be selfish. So I will, if you have more people asking questions in the waiting room, I will come back on a different time.
Oh, but what is your question? What's your question about? We can.
It's more myself. I already have a little one. He's 14 months, but I've done 2 continuous IUI cycles after just recently, and they've failed. My question is, we sometimes have, it's hit and miss. We sometimes have male factor. We sometimes don't. It's very weird. would it be best to go more IVF and have that straightforward? Sometimes, so our IUI cycles, we've had 9 million and then 4 million, just the past 2 cycles. 9 million's fine, 4 not. But obviously I'm going to scratch that 4 and not count it. And then so technically give myself 2 more IUI cycles, technically. But is it best to just kind of bite the bullet and then say, yes, we sometimes have male factor? Is it best just to go straight forward and do IVF?
That's a great question. I'll start this one since you started last time, Dr. Salem. There's actually plenty of studies out there showing how much sperm fluctuates. One of the most famous studies was a prisoner who was they had him get sperm twice a week for like 2 years, and the guy went from like 180 million sometimes all the way down to like 2 million. Sperm fluctuates by millions and millions. As a matter of fact, it's one of the first things I think of when I hear someone go, "Oh, I got pregnant one time after 3 or 4 years, and then we haven't got pregnant again." I think sperm issues or ovulation, because those are things that fluctuate, right? That can come and go. Whereas tubes, as Dr. Salem talked about earlier, don't just open and close. They're either closed or they're open. And so when it comes to sperm factors, yes, it does fluctuate. And I think one thing to feel good about is 4 million's actually not a reason that IUI won't work. We tell people we want about 5 to 10 million. There's several studies that show once even at 3 million, it's probably fine. There was even another study that showed even at 1 million, people get pregnant. But it's not just about the quantity; it's about the quality as well. But it's something you're doing the right thing. If you got pregnant without doing anything, to me, I mean, IUI.
It was my 4th IUI.
Oh, so it was IUI before in the past.
My 4th IUI. Technically, we had one that was. I didn't preface that. Sorry. Technically, we had one cycle the first time that was very low as well. I think like 1.5 million. And then the rest after that, we had like 18, 22. So plenty. But I probably am throwing you off because I'm under Kate Johnson, not Katherine Johnson. But I had early preterm birth. I had very early, 6 weeks. So we're trying to be a little bit more cautious. Obviously, I don't want multiples this time. I had multiples last time and lost one. So I think me having 1 to 2 follicles too is also playing a factor in it because we're trying to be a little bit more cautious, which is fine. I totally understand why. It's for the health. But that's also a factor as well, is we have to be cautious for my sake. So not having too many follicles, plus then also having male factor occasionally. Because when I did get pregnant, I had 3 follicles and 18 million. So the last 2 rounds, I've had 1 to 2 follicles only.
Dr. Salem, anything you have to add?
Yeah. I mean, it's, the thing, I think we'll take kind of like a step back and think kind of very broadly about, kind of IUI and how IUI, works to improve the chances. I mean, what IUI does is it's kind of aligning the stars, right? We're getting as much sperm as possible that's concentrated and it's been washed in the lab and spun, and we get it as high up into the uterus as possible so that it has a short distance to swim. So if there's less of them or it's less concentrated, they have this big head start. We're making sure that you have maybe an extra follicle, so you have 2 instead of just the 1, that you're ovulating right on time. So what we're doing is we're aligning the stars. That's kind of the way I like to think of it. But at the end of the day, the sperm still has to find the egg and they have to fertilize. And then it may or may not be a chromosomally normal embryo. And then it has to implant, and then everything else has to happen. So, by and large, the kind of optimal, the highest rates of success when we think about IUI tend to hover around the 20% mark. When there's different studies that show different numbers, but let's just use 20%. So the way to get success with IUI is you have to stack up cycles, maybe 1, 2, 3, 4 cycles. If you're really lucky, you get pregnant with that first one. But there is a point when you're doing IUI too, where you just have diminishing returns, and it's like, well, I've tried 3 or 4 cycles of IUI and they haven't worked. The sperm counts are consistently pretty low, et cetera. Kind of where do I go from there? And at a certain point, it's just kind of, to use your words, it's like better to just, bite the bullet and go to something that's much, much more efficient. Now, one thing I will say though about IUI, and when you have these fluctuating sperm numbers, is that it's important to understand like why the numbers are lower, right? Like 4 million
Right.
is low, but so is 9 million, quite honestly.
Mhm.
And one thing to do is to kind of try seeing a reproductive urologist. They are, there are like, counterparts on the male side. And so we work together on a lot of things, and maybe sometimes they uncover something that can really help boost those numbers and make IUI a little bit more efficient. But, I think it's kind of thinking about things holistically. I don't think there's like an ideal number of IUI cycles to try, and then draw the line at it. I think it's a conversation that you have to have with your doctor. And it also has a lot to do about your own, beliefs, where you are. Do you want to do things with a little less invasive, but takes longer, or maybe a little more invasive? How much does cost play a part into this? And you talked about twins. I mean, the twins are another big thing that occurs with IUIs. With IUI, it's more like of a shotgun approach. You're just
Yeah.
trying to get as many sperm by as many eggs as possible to a certain extent. So twins actually happen at a fairly high rate compared to doing a single embryo transfer of a euploid embryo with IVF. That's a much more precision targeted technology. So, there's pros and cons to both, and it's important to think of all those things.
Just
Makes
for
sense.
clarification, Dr. Salem, when you were saying 9 million is low, you're talking about pre-wash, not post-wash, correct?
That's right. Total modal count pre-wash. Yeah.
Yeah. And so when I was talking about the 1 million, to make sure people understand,
Right,
it's
right.
post-wash I'm talking about, not pre-wash. Those numbers would be horrible if those are pre-washed.
Yeah.
Well, thank you so much for your
Nope.
time.
Thank you guys. I
Maybe-
appreciate it.
Maybe you'll win the raffle, and then you'll be going on IVF anyway.
Yeah.
So
Maybe, right? Thank you.
have a good one, Kate. Yeah, I think I've told you this story before. It was really interesting. I had this patient come in who said they got pregnant with an IUI in the past. And what was interesting is she said to me, my husband's sperms are really low. She's like we're talking, you won't have even 1 million sperm. And I said to her, I wouldn't waste your time with IUI. And she's like, no, everyone says that. Every doctor says it, but we keep getting pregnant every time. And I'm like, listen, I mean, as long as you're okay with it, I just don't want you coming back saying to me, why did you let me do this? First IUI, less than 1 million sperm. It was like maybe 0.9 of like 1 million sperm, pregnant right away. So
Wow.
it's kind of the point that, I always tell people, I think IUIs are like Match.com. We're just getting everything a little closer together so they can have a relationship. And sometimes there's just some better sperm, even at lower numbers, than people who have high numbers with bad sperm. So
Yeah, I could totally see that. What I want to know more about is this prisoner who was having a semen analysis done every, what a great study to show us how the fluctuation of that all the time. But I think the other inmates were probably
going there, right? So I know there's a couple questions here, and I think we might be want to get to some of them. Here's one of them is, does the grade of embryo change if it is frozen for multiple years? I'll let you tackle that one, Dr. Salem.
Yeah, this is a great question. So it's important to understand a little bit how grading is done. The short answer, by the way, is no. It doesn't change the grade of the embryo. The grading is something that is done at the time the embryo is frozen. And the typical grading is a Gardner grading criteria. And it basically looks at the stage of development, how kind of expanded the blastocyst is. It looks at the inner cell mass, how tightly, compressed the cells are, how evenly spaced they are. And it looks at the trophectoderm, that outer layer of cells. And it's something, it's a very technical grading system. And the embryologists, over many, many years, looking at thousands of embryos, developed the ability to very precisely kind of grade the embryos. Now, your question is also getting at another thing, which is, if an embryo is frozen for many years, does its quality deteriorate? Because I think that's maybe what you're also asking a little bit. And so far, what we know is that it appears not to, though probably more evidence is needed in this area. There's been a lot of case reports of embryos that have been frozen for like 20 years that could then be thawed, used, and a pregnancy came from them. So we know they are viable. But the question is an embryo that is frozen for 1 month as perfect as one that's frozen for 3 months or one that's frozen for 3 years? Generally, yes. There are some very, very, very kind of nuanced studies that have shown that maybe there's a very small difference between some of these things, but we also don't know how to control for that because you're also putting an embryo back into the uterus. That's a really big variable. The last thing I'll say is that the technology that we use to freeze embryos now is extremely advanced compared to the technology that was used 20, 25 years ago. So this technology of vitrification to freeze the embryos makes it so that the embryos are, let's just call it, a lot more stable, a lot more hardy when they go to be thawed. And so we think that the change of the embryo, or like if there's any deterioration from being frozen for a long period of time, is probably very, very minimal. Now, that's highly dependent on being frozen in a perfect environment. And so that's, that the levels of liquid nitrogen are always perfect. The tanks are always perfect. There's never, the liquid nitrogen level never goes down too much to where the temperatures rise even a little bit. So those are other, things that are very important, things that we're very, very, very careful about in our lab.
I was going to add a part in just kind of a different perspective. I'm not sure where your question was coming from, but as Dr. Salem said, yes, there's not going to be a change. However, sometimes the grading does change. And it's like, well, is Dr. Salem lying? No, he's not. There can be other reasons for change. So, for example, embryos from one clinic to another clinic. When you talk about grading, it's a little bit subjective in some ways. And, you got some people who might be meaner and they're like, I'm not calling that a B. That's at best a B minus. And the next person gets it and goes, it's kind of like an A. And so, unfortunately, you think it would be very objective. But I always remind people, if you have to grade everything within 3 letters, that becomes very difficult. It's like I always tell people, trying to grade humans in the way they look in 3 letters. It would be very difficult to put people in those categories. And so it is possible that the grade could change, but it's not because the embryo changed, but really because the way it was graded. Maybe a different clinic has a different grading system. Keep that in mind. The other situation where it can come up is that embryos can sometimes, when they thaw, survive the thaw, but there could be some quality issues that develop afterwards, and that could affect it as well. But that's not that common. And so one of the things I wanted to transition in while we're talking about is Dr. Sim brought up vitrification. And what's important about that is that's kind of about the topic we were going to talk about tonight, which was about the ins and outs of egg freezing. And so one of the things that made egg freezing possible was vitrification. Because as you mentioned, the old way we did things was a very slow freeze. So they just get colder and colder very slowly. And as it eventually froze, and what the purpose of that was is to prevent crystallization. And so as everybody knows, water expands. That's why it sits on the top of water when it freezes. And so that's why the fish underneath don't freeze to death. Well, the problem with that is it expands and kills cells. But with vitrification, instead of freezing it, it actually ends up being in a glass state. And so it really doesn't get that expansion, the crystallization, and that lets the embryos survive better. And it also allows the eggs to be frozen. The caveat I'm just going to bring up about one thing Dr. Salem said was, we have this information about embryo. I think it was like 28 years or something. Someone thawed an embryo and had success with it. But vitrification hasn't been around 28 years. So we really don't know with vitrification what the limit is. But, if you ask me that question 20 years from now, well, then I'll be able to tell you maybe 30 years. And so we'll have some of that information. And I assume technology will get better and better eventually. And then there might be something newer. So I think one of the questions we had coming up here was, what would you consider the ideal age to freeze eggs? Someone recently told me women who freeze below 37 are less likely to use them. Would love to hear your thoughts. It's a great question. Sam, you want to start that one or you want me to?
Yeah, maybe I'll start tackling this one, and we can go back and forth. This gets to the heart of our topic today, and I think probably we'll have a lot to say about this. This is a great question because first of all, the the egg freezing, as we know, is something in which you choose to do it at one point or another. So at some point you have to say, okay, I'm going to do it next month. There's going to be a point where that's the case. But egg freezing depends entirely on when you hope to use those eggs and what your kind of bigger plan is for starting a pregnancy in the future. So finding like an ideal age is a little bit of a tricky thing. It's a tall order. But what I would say is there's a balance. If you freeze eggs very, very, very young, and you have a long runway in front of you in which you're going to have really good quality eggs for years, then you might be getting ahead of yourself a little bit. You might be freezing eggs before you really ever need to use them. So the younger you are when you freeze eggs, statistically, the less likely you are to use them. The flip side of that is as you get kind of older, the percentage of good quality eggs that will lead to a pregnancy decreases. And so when you're 42, 43, 44, there's a relatively small proportion of the eggs that will lead to a baby. And so you would have to freeze a very, very, very high number. And so I always really caution my patients who are freezing later in their reproductive years to really consider that they're going to have to do many rounds of egg freezing just to get an appropriate number of eggs. So then that leaves us with, well, what's the ideal number, or what's the ideal age? And I think there really isn't an ideal age. I think there's probably a range that spans somewhere, in my opinion, from the mid 30s to the later 30s. And the reason I personally think that those are the numbers is because around the age of 35 is when we start to see a really pretty significant drop off in the euploid rate that comes from those eggs, meaning the proportion of those eggs that are genetically normal that can lead to a baby starts to decrease. Up until 35, the decrease is very slow. But between 35 and 40, you have many eggs that are still viable, and you have many eggs in general that you can get from a single round of egg freezing. So that's kind of maybe where there's a little bit of a let's call it a sweet spot. But on the flip side of it, if you're 33 and you're sort of certain that you're not going to have children for 3 years for whatever reason, then why wait till 35 or 36 to freeze? You're going to have better quality eggs at 33. So it's like this very highly individualized decision-making process. And so what I would say is there's no blanket, do it before this age for everybody. I really don't think that that's the case. But I'll bounce it over to you, Dr. Amos, because I think there's so many different perspectives about this, and it makes it really interesting.
Yeah, I mean, it's the warranty question. Do I get the warranty on this or do I not? And you don't get a warranty on something that you expect not to use forever. You're like, I'm only going to use this for 2 weeks. Well, I'm not going to go warranty on it. But if you're going to get something that's going to last you a little bit longer, you might want to get a warranty on it. And so it's that same principle. And I think that's what you were, getting at is that, yeah, I mean, it'd be great if you could freeze your eggs at 18 years old, 20 years old when they're super healthy. But as you're pointing out, the difference between 18 and 30 is probably not that big of a difference. And so if you freeze them too early, now you got these eggs costing you money, sitting around. And realistically, remember, only 15% of people have infertility. Of those 15% of people who have infertility, most of them are going to end up having success anyways. So you're talking about a very small group of people at 18 that can know ahead of time that they're going to need to freeze their eggs. And so it's going to, not make sense when you're younger. But there's that concept in their heads that, hey, when you're younger, you're healthier, you're going to have better eggs. That's why people think that. I think where some of the age 38 came around was, this was very expensive at many clinics. We try to do affordable, but there are clinics that are very expensive. And so people looked at it and said, okay, at 38, you're at that tipping point. You're at that point now where things really start to get hard. And if you don't freeze them now, you're going to struggle anyways with fertility. So this is the time to freeze them because you're kind of at that last second now. You know, you got, okay, I got to do it now. And you probably, even if you don't use them, the warranty was worth getting because you're at that tipping point. I would say for me, I think 30 is probably, you know, a good age, but it depends on where you're at. Like you said, you know, if you've gone to 30 and never had one partner at any time, never even a relationship, you might go, okay, this may be a while. And if you don't want to try this on your own and be, you know, be a single mother or something like that, then yeah, freeze your eggs probably by before you get to 35. Or as I've always talked about, make sure you test your egg reserve. This is actually what I talked about at a meeting the other night when we were talking about egg freezing. A lot of professionals or people, you know, postponing having kids. I said, you know, you don't really have to just freeze your eggs. I think the more important part is just figure out where you're at. And so I think that's where ovarian reserve testing comes in really useful, because if you're on that, you know, that younger group and you're even thinking about it, and maybe you're like 30, you know, 28, 30, check your ovarian reserve. If it comes back and you're just knocking it out of the park, well, no reason to freeze your eggs right now. Just check it maybe yearly, every 2 years. But if you're someone you find out that it's a low ovarian reserve, then you might want to freeze them now. And so that thing before 37 about less likely to use them, absolutely, because you have so much time still to meet a partner and get pregnant. But realistically, 35 is that number we always talk about where you really should be evaluating things at that point. I would tell any woman who hasn't had kids, if they have and are even not considering freezing eggs, if you're 35, just get your ovarian reserve tested. Because if you're one of those women on the bell-shaped curve that's a little bit further out and the egg quality is not as good, you might have wished you would have frozen then versus at 37. 37 is kind of like at the near end. Like I said, at 38, at that point, if you're not freezing them then, it's almost a waste, because even if you do use them, it takes so many. I wanted to show that calculator. There's actually an online calculator, but I don't know if I'm going to be able to figure out how to show it on here. But when you are 40 or 42, the amount of eggs needed to freeze to be useful is so astronomical to have even an 80% chance of pregnancy that it's almost not worth doing it at that age. And that's why I think 37 is that number where they said that, you know, you really need to do it by then. So I disagree with what I think you said your friend told you or something, that really you need to be doing by 37, not worried that you're not going to use them at 37. But they are right, because you might just get pregnant naturally at 38 with someone.
Yep, that's absolutely right.
I just wanted to point out, there was a question someone asked about how to get on live. So there is a banner at the very top. Hopefully that's working. It's t.ly/SME for sperm meets egg, and you should be able to get on live. You can also always go to the website spermmeetsegg.com, and there's also a link on there how to how to get on the show. So anything else you have to add to that? And I think what we'll do is we'll talk to Kara here and go from there.
Yeah, I mean, I think like one really quick thing about this egg freezing bit, because I think it's important to remember that egg freezing up until 2011 was considered, you know, kind of experimental. And then it slowly picked up, and then it's kind of really boomed in recent times. And what I will say, you know, is that I think part of any good egg freezing consultation really needs to include what the plans are with those eggs and what your fertility goals are. And it is so not a one size fits all for everybody. The flip side of that same coin is, I think that, you know, reproductive health span and lifespan. We talk a lot about lifespan of, you know, just general health, but reproductive lifespan, the number of years in which you could have a baby, we're really trying to extend that because of society, because of everything. And I think it's really important to be proactive about our reproductive lifespan. And that includes these things that Dr. Amos was saying. You know, get your ovarian reserve checked out, have a conversation about these things, maybe consider egg freezing. These are all things that are important. You know, people are constantly doing pap smears and mammograms and all these other preventative measures. We rarely think about preventative measures for reproduction. I think it's really important too.
Yeah. And I'm sure you probably said this to patients before too, you know, it also depends where they're at, right? So for example, like if someone has a high risk, let's say they've had a major pelvic surgery or PID, so well, check to find if your tubes are blocked. And if they are, because you had 2 episodes of, let's say, an infection in your pelvis, well, then you're going to need to use IVF someday anyways. And so, you might want to just freeze your eggs because you're going to have to do it eventually someday. Well, let's go to Kara here and bring her on. All right, you want to help with that? Thank you.
Hi there.
Hey, Kara.
Thanks for the great combo tonight. I did try the link at the top. On my phone, it didn't work. But
Okay.
the Sperm Meets Egg website worked great, and it was really easy. So,
Perfect.
just when I typed it on my phone, I don't know, nothing. Just like the website popped up. I mean the little like I don't know, the little shortening website popped up. Anyway, my question was about like current technology and what you all are like hoping for in regard or anticipating um like for future technology that can make the biggest difference for IVF or for fertility, kind of like what's not very efficient right now that there is room for, something really innovative to come along or something that would like, either improve the patient experience, like a better EHR, or is it self ultrasounding? Like, there's so many cool things about technology. Just wondering, from your perspective, kind of maybe something innovative that you're looking forward to coming to the market.
Yeah, I'm going to just start this one real fast to say that I don't think anything we do right now is great. As a matter of fact, it's horrible what we have to do. We have to pump women full of tons of hormones to hopefully get 8 to 12 eggs and try to help them get pregnant. What I'm hoping someday is that we're going to be able to take a little biopsy of ovarian tissue, and then we can grow 1,000 eggs in the lab and with very little medicine, and then we make embryos that way. I mean, I think that's where my hope is. I know people are working towards that. There's been some very small, I don't know, studies, but situations where they've actually put like ovarian tissue underneath the skin. But I think what we do right now is practically barbaric. I mean, it's insane what we're doing right now. It's the only thing we have, so it's great. I mean, I got my kids because of it, but at the end of the day, I'm looking forward to things like that. I think we are just in the beginning. And what's interesting right now is there's a lot of money coming into fertility, like a lot of venture capitalist money, because what we're realizing now is that fertility isn't just about people who have problems having kids. Now fertility is about things like, if there's a disease that you're trying to rid, maybe, eventually, I mean, I hate to say Gattaca, but I mean, like, you have your designer baby and stuff like that. There's a movie called Gattaca. I'm a little bit older, so people may not realize that one. So I think we're in the very beginning. I'm excited about a lot of things. I'll let Dr. Salem talk about some of the stuff coming out, but I truly think what we're doing now, like someday we're going to look back and be like, you pump people full of drugs and got only 8 eggs? Or like, we get 1,000 doing this. And so I think there's going to be a lot of changes in the future, and this is going to become a lot easier than what we're dealing with now. So.
Yeah. One thing that I love about, working with Dr. Amos is he's definitely a futurist. He's kind of in our field a futurist. He's always looking about, okay, what's the next thing? What's the best next thing? And I think that's so he's really looking now 2-3 steps into the future with that stuff. I hope that is within our career, Dr. Amos, that we get to be there for what you just described. I think, what I hope to see in the next 5 years would be things that integrate a few different things. Number one, I want this patient experience to improve. I want it to improve because it is such a big ask for all the women out there going through IVF, through egg freezing, to come into the clinic 5-6 times over the course of 2 weeks, to get their blood drawn every time, to have an ultrasound done every time they go. They're really putting themselves out there. It's a big investment of time, and just a lot of them to go through all of that. So what I'm hoping to see is, number one, a bloodless IVF cycle, meaning I really want to see our ability to understand the hormone profile by just looking at analytes in the urine. I also want to see AI-assisted ultrasound technology in which people can take home a probe and do their ultrasounds at home, and then the images are sent to us over the MR, and we will tell you how to adjust your medications based on that. You don't have to come into the clinic 5-6 times. You just come in one time, and that's for the retrieval. And then the last thing, and I think this is true of every IVF center out there, is there's a lot of communication in IVF, and it's sensitive communication. It's communication that is very time intensive. It's time sensitive. And I think, Kara, you mentioned the EMR and that whole technology. And I think we're continuously making improvements in that realm, but we have a ways to go. And I think that that's something I'm really excited about, that I do believe the future will make this more pleasant for our patients. And those are three things that in my mind are just going to make the patient experience a lot better. There are a lot of other things that will make the science better, I hope, in the next 5 to 10 years. But patient experience right now is a really, really big part of it. We do everything that we can to optimize it and make it good. But I think we do need some technology to improve that as well.
Thanks for your insights. That's really helpful.
Can I ask you a question?
Yeah.
As a patient, I think Dr. Sam, hit the nail on the head. Even when I was talking about, being able to do a needle, it's again about patient experience, right? That makes things a lot easier. We have to come from one appointment, everything's growing, you just show up for transfer. For you right now, what do you think would impact patient experience the most? Like for you, if you said this would really make it better or stuff like that you want?
Yeah. Well, I'm a little biased. I work at an EHR company. But like it has nothing to do with infertility. And so I often am like, because I'm passionate about infertility and I've gone through that whole experience, and I continue to go through it as I try to expand my family. I keep thinking like there has to be a better way of equipping the patients with their like information, because I mean, of course, doctors are like the best thing ever, but the patient the patient knows themselves also and can do a lot with data, but the data isn't really at our fingertips after we let it go. Like we are the experts of ourselves, kind of. And so I think that a lot of patient advocacy could be improved if some of that information was easier at our fingertips. And so I think that would improve like my general experience, like just seeing it like in a clean user interface, or, just like feeling empowered as a project manager of my own IVF cycle. So I guess I kind of see that as a area that we could improve on. And I love the concept of the ultrasounds at home as a travel patient. Just finding the outside monitoring clinic, and like it's such a crazy like loopholes of working through insurance and just like all these crazy things that we have to do. I feel like that would be a major improvement as well, for especially travel patients that aren't as close to the clinic but know that you would be able to get that data so seamlessly from like the comfort of our homes, I guess. So thanks for sharing that.
Well, I love your answer, and I appreciate you sharing that, because what's funny is, and Dr. Salem knows, is we are actually been looking at EMRs. As you mentioned, and in case anyone doesn't know what the word EMR means, an electronic medical record, there has been a change in the industry. Before, EMRs did one thing, and that was hold digital information about the record. That was it. There was never about the patient, right? And then later has been this kind of change, like for the patient portion, right? Where now it's interaction. Right. And in our field, it's a very small field, right? So there's not really many EMRs out there, and most of them are okay. So we're actually looking at a EMR now that is pretty revolutionary in some ways. It's actually patient-centric versus being clinic-centric. And so it started actually as an app for patients, for them to keep all their information together that they could see the charts and see the growth and things like that. And it integrates with the EMR. Then they made the EMR around it. And this was actually created by a person who went through 7 IVF cycles. So they went through this stuff and they were like carrying around all this stuff. And they're like, there needs to be something better. And so I'm not saying we're switching over tomorrow, but I say that because it's one of those things that are in mind. And we're like, do we make this switch? And hearing this now makes me feel really good about this. So,
well, if you need a beta tester as a New Direction patient and an expert in the EHR field and behavioral health, I'm happy to apply my knowledge and help out in any way that I can, because the patient experience at New Direction means a lot to me, and that sounds exciting that you're moving in that direction. So there's some synergy there that is awesome.
Well, I'll definitely be reaching out to you.
That sounds good. Well, thanks for your time tonight, and continue to push the boundaries on new technology. I think that's really great, and is one of the major things that attracted me to New Directions in the first place, because everything is just like so fresh and brand new and just like cutting edge, and I really appreciate that aspect. So props
it's important.
to you all.
I mean, it's definitely important. So thank you so much.
All right.
Thank you.
I know we're getting near the end here. We're getting at 7. And so there was a couple questions here I thought would be good to kind of get in. One of them was about egg freezing, which is great because it's the topic we want to talk about. If you freeze good quality eggs, do they stay good? Kind of we touched on this a little bit earlier with the embryos. I would say the same thing. Anything you have to add to that, Dr. Stanley?
No, I will just say good quality for eggs is different than for embryos, right? So we actually don't have a grading criteria for eggs. They're just mature eggs or they're not. It's kind of binary. So I will say that when you freeze eggs, we tell you how many you froze, but I would just take that number at face value. That's it's just a number. They're not, good, best, poor, anything. They're just eggs that are frozen.
Although one thing that we saw when we were at a recent conference is there is a company now that takes a picture of the egg and can use that image, and they say they can help determine how many of those will actually make it to blastocyst later. Now, that's a pretty tough thing to do because remember, we talk about how sperm can be a big part of this, right? So you get the best eggs in the world, but if you got, bad sperm, then you're still going to have some issues with embryos. But it was actually kind of interesting, and it's actually a company we're talking to now. It's using AI. And so the thought would be is that by looking at this cohort of eggs, they could give you a general idea that, okay, you're going to need more eggs or you may not, that's enough. And so that was actually pretty interesting technology I saw at this conference. Anything else? I'm trying to think if there was anything else I saw on egg freezing. That was probably the biggest thing I saw was the AI for that.
That was the biggest one. Yeah. I'm very excited about that one. I mean, that would be a big, step forward in terms of innovation, in terms of predictive analytics for egg quality. And something I'm really excited about, quite honestly. This is one of the things I'm most excited about. But the data, it's still, let's call it early.
Yeah, they're very early. And that's why I feel like it's something that's no one's going to use a lot right now. We're working with the company now to offer patients the ability if they want that. And it will just be kind of like an add-on for now because it's not something that's been proven enough for us to feel comfortable that we're going to give to everyone right now. But it's some neat stuff. And so it kind of goes right back to some of those questions and what Kara was just saying, always trying to be innovative and trying to get new things. Well, anything else you want to end on? I think for me, the big thing I want to end on with egg freezing is that, it's something that's a personal choice. It's really important to involve a doctor in it because you can't just go to a website and say, well, here it says you only need to do it 30. There might be a reason you need to do it before 30. So you really got to get that kind of personal choice, talk to a doctor, or come on this show and we'll help you make that decision for you. But when it comes to egg freezing, the thing is talk to a doctor, find out your ovarian reserve, and most important, have an idea of what your plan is. And that's where the doctor's going to be able to help you make those decisions. Because if you want 9 kids, yeah, you might need to start freezing eggs if you're only 35. And so those are some of the things that we would take into consideration. Anything you want to end on, Dr. Salem?
No, I love that. I mean, it's just a highly personalized decision, and you have to come and bring all of your reproductive goals to the table and say, hey, Dr. Amos, this is what I want, A, B, C. And then we're going to create a plan for it. And that plan might include egg freezing, and it might include, doing nothing at all. But I think it's good to be proactive.
And thank you for all the questions. I know there were a lot of questions we didn't get to. You will still be entered into our raffle. So every question, again, gets at least one entry. Being on the show gets you 5 entries to the raffle. And I appreciate all the questions. I'm sorry we couldn't get them all, but our wives are going to kill us if we don't eventually get off every night. So thanks for everyone being here. Dr. Salem, thanks so much for doing this with me too. I appreciate it. We'll see you guys in about 2 weeks, and see you then. Thank you, Ari, too. It's very important that we thank Ari because she is the glue that keeps this going.
Absolutely.
I just want to add one thing before we close off, just so everyone knows, anyone who submitted a question via live with the doctors or through the chat, your name is on a spreadsheet, so we did not forget about you. I have all of your entries on there, so it is safe and sound, so they are counted, just to let you guys know.
And so please tell people about how come on live. Like I said, now there's a true benefit for you. Not only do you get to talk to us, but you also have a chance to potentially win certain things such as free egg freezing, free IVF, and big discounts and things like that. So we look forward to handing these out for people, and look forward to the next show.
Take care,
Have a good
everybody.
one, guys. Bye-bye.